Oh, that would be nice. So it looks like I'm live. Okay. So I'm going to be talking about aging and medication. Medication adherence to me is an everyday memory activity that I look at. My name is Kathleen Insel, and I am at the School of Nursing here at the University of Texas Health Science Center, San Antonio. First, I'd be very interested in knowing what you may think cognitive aging refers to. And I guess I have to ask the people that are in this room right now what you might think of when I say cognitive aging. What does that bring to mind? Anything. Cognitive aging.
Dementia.
Dementia. It's my usual response. I've been finding out that I have a little bit of trouble communicating exactly what I'm talking about when I'm talking about cognitive aging. And what's the reason for this? Because a lot of people think that age-related cognitive change means that we are talking about dementia, and that is not the case. Age-related cognitive change are those changes that occur in memory and thinking that occur normally with aging. Okay? So I don't think the same way that I used to think when I was in my 20s, unfortunately. Or maybe fortunately, because there are some benefits to that. Certainly, I'm not talking about dementia. I'm not talking about depression. We know that depression has significant influence on the way we think and remember. And I'm also not talking about delirium, which is an acute confusion in relationship to thinking and remembering. So changes that are the consequence of medication or dehydration or fever that we often see in the hospital. Okay? So what am I talking about? Whoops. Excuse me. So this talk will focus around two questions. Why should we be interested in medication adherence for this age group? And how might the task of remembering to take medications be different for a population of individuals who, although they are older, do not show any signs of dementia? Now, with the aging of the baby boom generation, what we're seeing are increases in percentages in relationship to the population. Although older adults represent only 12% of the population, they consume more than 36% of total healthcare expenses. Now, 11.4% of acute care admissions for the elderly are related to non-adherence to prescribed medications. Also, we know that an additional 16.8% are related to adverse drug reactions. Many of these might be the consequence of taking medications inappropriately. In relationship to importance also, and why we should be looking at medication adherence for these older adults, 50% of medication prescriptions are written for older adults who each may be taking at least 3 medicines or more. The large number of medications to remember and track adds to the complexity of medication adherence in later years. Non-adherence is problematic. I don't have to tell you when you are trying to regulate someone's blood pressure, improve their mobility, or treat an infection, you count on the patient to follow through. Because when you don't perceive that a therapeutic level of medicine has been achieved, you're likely to increase the dose or try another medicine. Each action is dependent on the supposition that the patient is taking the medicine. Other problems that are familiar to you and that are described in the adherence literature include people taking drug holidays, so they go off their medicines for 3 or more days. Also described as the white coat phenomenon, so you might not think that you have a lot of influence on your patients, but 3 days before they come to see you, you better believe that they will be adhering to their medications. So clearly there's a direct link between the optimal medication regimen and increased mobility, decreased mortality, and improved quality of life. Our desire to support the independence of older adults and the desire of many elderly to maintain independence may depend on accurate and consistent medication taking. Okay, now a recent report, and something I've been hearing across the circuits, suggests that our older adult patient population is now healthier than in generations past. Therefore, they're less dependent upon drugs or medical interventions. While this may be true in terms of the percentage of older adults who have chronic illness compared to those who do not is not the case in terms of overall number. Now, this is something that constantly comes up in my research classes. Percentages don't really tell you what's going on. It's always percentage in relationship to what? So we're still seeing an increase in the overall number of individuals with chronic disease, as well as an increase or a decrease in the overall number of older adults with no disease. So clearly and concurrently, there is an overall increase in those with comorbid conditions. So in response to the first questions, we know that there are more older adults taking more medications with longer life expectancy and consequently greater chronicity of disease. We also know that failing to consider how people are adhering to medications can increase the cost of health care and in addition have variable effects on quality of life. If we assume that we're giving medicines for good reasons, then improved medication adherence should improve quality of life. Now, in response to the second question, why would we be differentially concerned about older adults and medication adherence? First, let's define what we mean by medication adherence. Medication adherence is defined as taking the right prescription at the right time, and that's often a window of time. So non-adherence they can be acts of omission, so forgetting to take your medicines, acts of commission, so taking more medicines than what are prescribed, acts of timing or sequence, or taking potentially interactive medications. Now, in behavioral kinds of science, what we look for are theories that help us inform what people are doing and why they're behaving in the way that they are. And there have been several theories that have helped to inform us about medication adherence. One is the health belief model, or this issue of benefit versus burden. There's also this concept of being a partner with the patient. So there's this notion that non-compliance or compliance predicts a difference in the relationship that we no longer potentially believe in. So what we tend to talk about are whether or not people are adhering to what we've prescribed, but compliance in terms of our dictating what they should be taking and how they should be taking it, it's kind of gone out of vogue. There's also this notion of illness representation, so how people perceive the severity of their illness and how they perceive the efficacy of their medications are going to influence medication adherence. So age-related cognitive change may be an additional component in explaining medication adherence among older adults, and it's the one that I have focused on. First, I believe that age-related cognitive change will predict the ability to care for oneself, and that it is this aspect of functioning that determines to some degree to which others become concerned about older adults living independently. So it's the fear that the older adult will forget to turn off the burner or forget to lock the front door that moves adult children and healthcare providers alike to question the viability of continued independence. Does this mean that the person has dementia? Not at all. So in relationship to what we've learned in the laboratory, we know that there are systematic and developmentally normal age-related changes that occur in thinking and remembering. Age-related changes are found in our ability to learn and retain new information. They're also found in older adults being less able to retain and manipulate information, or what we call working memory. These are executive functions that include planning, organizing, and strategic tasks. There are also age-related changes in inhibitory control. Older adults tend to be more easily distracted than younger adults. So I don't know if you remember or if you have teenagers, but when I have music playing now, I find it distracting. When I was younger, I could have music going, I could have people yelling down the dorm, floors, and it wouldn't be distracting. But as we age, those things become more distracting. We also know that older adults are slower at information processing and perceptual speed. So our hypothesis is that working memory, or executive function, or frontal function as some people call to it, can predict the ability to live independently. And the theory related to this is that we have a decline in self-initiated processes as we age. Okay? Now, because of this, we're going to see changes in prospective remembering, which is remembering intended actions. So Remembering that I intend to do something in the future. Prospective memory. Those things will change with age, particularly. In the labs, we've learned that when these tasks are time-based versus event-based. So most of the physicians that I know will link taking a medicine to a particular event during the day. Take them with breakfast, take them with lunch, or take them with dinner, or take them in the evening before you go to bed. So linking to an event these prospective tasks, like medication taking, is very helpful because you don't see the differences in the lab between older adults and younger adults when it's linked to an event. Also, there are differences in source monitoring. Now, why is this important? Because source monitoring has to do with remembering the context, the time, the place, the action. And in my work, source monitoring is about, did I take this pill this morning, or do I think I took it because I've been taking it every morning for the last 2 years? Okay? And that's when we start to see these differences in what is habitual and the benefit of something becoming habitual and the actual event of remembering, did I take it this morning or not? And there are also differences in temporal order. So people forget what sequence more easily as we age. And I think because we start to group things, but that's just part of where this theory is coming from. So when I teach my students about research, one of the things I talk about is how do we get smart about something? And so how do we get smart about medication adherence? And in behavioral science, what we have to do is we have to structure some of our correlational information into a causal model. And that may be a very different way of thinking about these things than when we think about it from a biological perspective, where we have a cause and effect and we try to look at those cause and effects. What we're trying to do is take correlational data and try to structure a causal model from it. And this is the causal model that I have been working with. And I get smarter about this as time goes on. So what I'm particularly interested in is this relationship between cognitive ability, which does not necessarily mean dementia, and medication adherence. So what I'm suggesting is that as people age, what we know from the laboratory is that there should be differences in our ability to perform these everyday tasks. And then remembering if we actually perform them. So what influences cognitive ability? Well, there's evidence that illness, the type of illness, informs cognitive ability. We know that chronic hypertension, uncontrolled hypertension, is going to influence cognitive ability. We know age does influence cognitive ability, and we know education influences cognitive ability. So education seems to have some protective effect. So when we look at these things, what I'm trying to identify at this point is who's at risk for medication non-adherence. Who would we be the most concerned about? And then looking at some nursing interventions that might improve medication adherence for that group of people. So, and I also want to point out that age alone is not a very good predictor of cognitive ability. So I have people who are 85 and who score very well on the cognitive battery that I give them, and people who are in their late 60s who are not performing well on the cognitive battery. So I'm sure that you've seen this also in your practice. So age alone is not a good predictor for who's at risk. So we're trying to come up with other predictors of what would cue us to understanding that someone's at risk for problems living independently. In the structural equation model, I also have symptoms. One of my theories is that symptoms will help cue medication adherence. So people who are having pain are more likely to be adherent to their medicines versus people with hypertension who may not be symptomatic with their hypertension. Symptoms also influence the regimen complexity, and regimen complexity can influence medication adherence. So it's been described that people who are taking more than 1 or 2 medicines are less likely to be adherent to medications. I'm not sure that that same pattern exists in our older adult population because I have seen people whose life revolves around their many medications because their illness drives their life. Okay? So there may be a curvilinear relationship in relationship to regimen complexity and medication adherence, and I'm not sure what that is yet. We're still looking at that. Also, obviously, drug costs may, for certain portion of our population, influence medication adherence. So the more expensive the medicine, particularly if the person does not think that their illness is severe or that the medicines are very helpful, is less likely to be adherent to medicines. Interestingly, busyness has been demonstrated to be associated with medication adherence. This is particularly true when you include people who are middle-aged. And I'm sure that there are more people out there than myself who would qualify in that particular category. But busy lifestyles have been shown to influence medication adherence by decreasing our adherence to the medication regimen. Interestingly, the busyness scale that's been used has a component of routine on it. So there's a sub-portion of those questions that focus on routine. And I would also suggest that routine is going to improve medication adherence. So if you're doing the same things every day about the same time, you're going to improve medication adherence, and that's one of the things I'm looking at. Resourcefulness may or may not influence medication adherence. I've seen people who are cognitively compromised in terms of demonstrating clear cognitive aging effects, or even demonstrating mild cognitive impairment, who are very adherent to their medications. And how they're able to do that is a lesson for all of us in relationship to our ability to tell others, how to get that done. Income, may or may not influence medication adherence for the same reason that drug cost does. Near vision has been suggested to influence medication. Social support and value, the value, as I've alluded to, that people place on adhering to their medicines. Medication adherence is also, in my work, hypothesized then to directly influence health-related quality of life, independent living. So if you're more adherent to your medicines, you're healthier, presumably. You have fewer visits to the doctor. You're able to live independently longer. Your healthcare utilization decreases, and your costs will decrease. Okay, and that's the importance of this work. There are two investigations that I'm currently involved in that speak to this particular area of research. One is a descriptive study associating age with cognitive change and using that to predict problems with independent living. So, what I do is I try to, I get a cognitive battery, which I'll show you the elements that are on this cognitive battery, and I look at that in relationship to predicting risk. And another is an intervention study, and this is a feasibility study that I'm doing right now to inform some funding decisions, hopefully, that will be made about applications that I will make in relationship to intervention studies. Okay. So the descriptive study is an exploratory investigation. I don't know why McAfee is starting at this point. Excuse me, let me see if I can get this to stop. Why we're doing a virus scan in the middle of this talk is a little bit problematic. We'll just get rid of it. Thanks. This is an exploratory investigation on the nature of risk for non-adherence to medication among community-dwelling older adults. And the investigation begins to describe, again, I know I've said this, the influence of cognitive ability on medication adherence. Specifically, the investigation is designed to examine the pattern of cognitive ability and how this pattern predicts remembering to perform an everyday function. So I've chosen medication adherence in part because I can get a tangible outcome, something that I can measure. I can't measure if people are locking their doors. I can't measure if people are leaving the burner on. I can measure whether or not people are adhering to their medicines. In other work that's been done, there are two latent factors, cognitive factors, that have been used to examine both remembering content, the item, which most older adults, learn that what these medicines are and when they're supposed to be taken. So that, to me, is not the problem. But also, this cognitive battery has been used to predict whether or not people remember the context in the lab. Therefore, I'm looking at factor analysis of a cognitive battery to identify the risk of non-adherence in the population. So again, there are sizable within-group differences within each age group. The pattern of cognitive ability may be useful in explaining these disparities, and can cognitive ability predict risk factors? So, implications for our community-dwelling elderly are unknown currently. I'm going to go right through this. Does age-related cognitive decline affect everyday functioning? If yes, then how is functioning affected, and then what can be done about it? And what I've got, again, is a battery of cognitive instruments, and the battery includes tests that should load on what I'm calling either the frontal factor, and it's not me that has called them this. This work has been done by someone else looking at these issues in the lab. the frontal factor and the medial temporal factor. The cognitive battery includes the Wisconsin card sorting test, a controlled oral word association test, mental arithmetic, backward digit span, mental control. If you know these cognitive tests, what you're seeing are both tests that are working memory executive tasks and also tasks that are more related to just remembering in relationship to whether or not people can retain the content. The design is descriptive. What this particular pilot that I'm reporting on today looks at is the effect of the pattern of cognitive ability and the presence or absence of symptoms and the interaction of cognitive ability and symptoms. This particular study, all my work is done in the home. I also see people in the community center. Occasionally I can get people to come into the university, but it's a very different kind of work than having a lab, you know, with a bench where you can actually do something, you know, in a very controlled environment. These people are subjected to lots of different influences. They're listening to news reports. They're hearing about somebody talk about memory. So it's not a controlled environment. This is field research. And believe me, it's a lot, I think. It's harder to go out there in your car on I-35 in the middle of the day, you know, and get to these homes and identify where these people are. So these are community dwelling older adults, 70 years old or older. They're living alone because it's my attempt to control for social support. The ones that I've looked at in this pilot that I'm reporting are hypertensive, and they are on at least one prescribed antihypertensive agent. I've also screened out people who are depressed and people who have dementia. Why? Because we know that people with depression, that it influences their cognitive function. We also know that people with dementia are at risk. So I'm not looking at that population, so I've screened for those. Medication was counted at the beginning of the study and at the end of the study, and I looked at this for 70-day interval. This particular group had 11 people. There were 2 men and 9 women, which is not unlike, you know, our population in the older age group. There was a relatively low incidence of non-adherence, and one of the problems, the frustrations that I have had is using pill counts. It's just fraught with problems. People have said, oh yeah, you know, the pharmacist sent me a few more because I ran out last time, or I dropped some so I threw out the ones that dropped on the floor out. Well, how many did you drop? Oh, a few. You know, there's all these sort of vague kinds of reports. So pill counts has been very difficult to track. And that clearly also has implications for everyday remembering. One of the things that can be used that improves this kind of research is electronic monitoring, and that's what I'm using currently. So every time, what this is a cap, a medication cap, so every time the patient actually goes into the bottle to get their medicine, the time and date is recorded so I can see also when there are problems with them, you know, taking the medicine in a particular way at a particular time. Okay, so they might be taking them at 3 a.m. because they woke up in the middle of the night and realized, oh, I forgot to take my medicines yesterday. So I can see that with this particular methodology, and that has really improved things tremendously, but that is not what I'm reporting today. So of the 11 people that I did with the pill counts, the mean pill count was 65.5 number out of the 70, which, as you would think, would be a pretty good number out of 70 days if they're adhering to 66 days of taking medicines. The problem is we can't tell if there were errors of commission that I couldn't catch. And again, you know, the lack of reliability with pill counts is a real problem. The age of these people is about 78 years. The number of medications that they're taking is about 4 per day, and that's pretty consistent with this population. That's the number of meds that they're on. Strategies, I was very interested in this. What kind of strategies are people normally using? Because it's the strategies that I think community nurses can be helping people to employ. And most of these folks are not using medication organizers, but they are organizing somewhat around a routine, which is helpful. What you're going to see here is just evidence that this is a pretty, all of these tests are normed for the age and education of folks, and these are pretty standard responses. So this group of people were fairly consistent with norm averages that we see on these tests. this particular slide gives you information about the factor loadings of these. Now, with only 11 people, you can't really do a factor analysis, and this was an exploratory factor analysis. It was preliminary work. But what I am finding is that there's clearly something that hangs together about all of these cognitive tests. So that's not what I would have predicted. I would have predicted that there would have been a sort of grouping of tests that have to do with frontal factor cognitive function and a grouping of tests that have to do with medial temporal lobe function. And I didn't see it with this low number of people, but again, you know, the parameters that were used indicate to me that, you know, I just didn't have enough number. And again, it depends with factors, you know, it depends upon how you're rotating the factors. What we are seeing, and I used a Spearman rank correlation to look at this, is that there does seem to be a relationship between the pill counts and the factor ability. So how people are doing on the cognitive tasks does seem to be related to how adherent they are, and that was one of the things I was trying to get at. So again, the goal of this particular research is to help people live independently for as long as possible, and also that to indicate that minor forgetfulness can have major consequences on adherence behaviors, and it does influence what you see then in the clinic when these folks come in. You know, how reliable their medication taking has been is going to influence what you end up doing, and that, you know, that can be a problem. Okay, I tend to end with this. So it has been said that a test of a people is how it behaves toward its old. And hopefully I've made 2 points. One, that as we age, the way we think and remember does change, and that might influence other everyday kinds of abilities to take care of ourselves. And that these changes can provide a window on how best to support the continued independence of community-dwelling older adults. So that's it. Are there any questions? Yeah.
What do you think about the older learner going back to school or older student, whatever?
Well, there's a lot of evidence that indicates that it's use it or lose it. In the memory work that's reported in cognitive psychology labs, clearly people who continue to be stimulated intellectually do better over a longer period of time. That's confounded by a couple of different things. I don't know how many of you noted the recent reports in Time magazine, I think it was, on the NUN study, or how many of you are familiar with the NUN study. This is a wonderful study and wonderful opportunity, because what we were able to do was to look at a group of people who were living in the same environment over a 50-year period, eating the same kinds of foods, subject to the same environmental influences. So as close as we can get to a controlled experiment with everyday life. And clearly people who, there were 2 things about this, people who demonstrated superior literary prowess at the beginnings of their time in the convent. So people whose descriptions of themselves and their families were a lot more rich, as they called it, were able to avoid Alzheimer's in later years. So that group of people, that prediction then that they would have Alzheimer's disease was limited. There are 2 things that go with that. Perhaps if you have better ability at the beginning, you're more apt to do those educational kinds of things that keep your mind stimulated longer. So it's a little bit confounded in these naturalistic investigations. You don't really know what comes first, the horse or the cart. But we do know that staying active intellectually is great. I just heard a report on NPR about a woman at 65 giving the commencement address at St. Philip's College. She was excellent. That's right.
Better than the speaker.
And the truth is, this is a woman who clearly demonstrates ability to learn and to think, and probably has always been a good learner and thinker. But it's striking if people do continue to learn over the lifespan, the influence that can have. And the other thing, see, I keep coming back to is some of the people that I have are very smart, but the premise is that they were very smart at the beginning. So even though they have incurred potentially some age-related cognitive change, they just you don't see it in relationship to what you would start to think of as mild cognitive impairment. On the other end of the spectrum, I have a person right now with a 4th grade education, and she scores 20 on her mini mental state exam. And you would be very concerned about her, but if you norm her for her age and her education, 20 may not be as impaired as you might think, and she truly is demonstrating evidence that she can live independently. So we don't know, just by virtue of how they're scoring on a screening task, the screening test of the mini mental state exam, you know, whether or not they truly are having problems living independently. As long as she's in her same environment. Of course, she's the kind of person also that you would be concerned that anything that's going to tip that balance might tip her into the realm of not being able to live independently. It's a good question. Anything else related to medication adherence or to what I'm trying to do in the community or to looking at these cognitive factors?
Have you seen patients due to economic reasons maybe try to circumvent their medication compliance? Because I've seen patients, I think of diabetics, where on a script you give them a 30-day supply and say it's with glucophage, 1,000 milligrams.
Yeah.
The last 2 months.
Yeah.
And you
Yeah.
catch it when they bring their bottles back.
Yeah.
Did you see
Absolutely.
anything like that?
I've seen people who have shown me in their home a script that someone had given them because they were no longer taking that medicine. But the medicine, although this was the conjugated estrogen progesterone combination, and they were only, this particular individual was only supposed to be taking the Premarin, and so this friend had given her this other stuff, and to try to explain to her, well, yes, you know, this is the same amount of estrogen that you're getting, but there's something else in here that you weren't prescribed, and so you need to discuss this with your doctor. Well, this person was unwilling to discuss it with the doctor because she didn't want the doctor to think that, you know, she wasn't doing as prescribed, but this was going to save her some money, and so that was a motivating factor for her. And there are people who don't fill their prescriptions. It depends upon how the message of taking the prescription is delivered in some ways. You know, like, is this really important, or should we try this and see if this works? And if it's an expensive medicine, they may not. I mean, I do believe that that's an influence on whether or not people are adhering to their medicines, particularly for some folks. So that's a good question. Thank you for sharing that. 'Cause, you know, the medication adherence, while I'd like it to be a nice, clean outcome of cognition, there are all these other factors that are involved with it. So that's why I have to look at all these other factors, because the variance related to cognitive ability may be lessened by some of these other things that are really motivating the adherence behaviors. Okay, anything else?
You know, didn't our speaker who addressed Alzheimer, was it yesterday, that said, you see, I'm really fitting in your category here of memory loss. And you had asked the question about how education was, you know, it was a factor in there about the more educated seemed like less prone to, and yet he didn't, at least to me, didn't quite explain that one as well. Do you find the correlation between the higher education and the
Well,
incidence?
that's what the NUN study demonstrates. However, there are so many other factors, ApoE. You know, there are other factors that are going to predict whether or not someone actually gets Alzheimer's. So to look at just one factor, that's the problem with, you know, working with people. You know, these field research is a much more complicated, we just can't do a clean study in this sense. So there are all these other factors that might be related. So that's why he might have skirted the question, because you can't say for sure. And sometimes it's a constellation of things that come together.
But is it not that stimulation that you
That would
mentioned
prevent Alzheimer's?
that would, well, certainly would help delay it, or so to speak?
It depends. You know, I mean, I can think of people who are cognitively active, who have stimulating lives, and who have a diagnosis of Alzheimer's. So it's not going to protect you, you know, 100%, 90% for sure, because it's all these other factors, and some of which we don't even, we haven't identified at this point. So that's why you're getting these kind of nebulous sort of responses because people can't say yes or no, and it truly is a sort of constellation of things that go into the picture of whether or not this is the case. So no one thing, but clearly maintaining an intellectually stimulated lifestyle is connected, is correlated with living independently longer and with having better cognitive function in later years.
Have you seen any difference in, this isn't really brought out in what you were looking at, but people who have a well-defined work history are more compliant with taking medication than people who have never worked or who do not have a good work history in not taking it?
I think that's a really good question. The question has to do with whether or not people with a work history that was, in fact, I'm beginning to think that people who were in the military are particularly adherent. So if you are used to having an established routine and if you do these things as you're supposed to be doing them, I think that that very well may be correlated. What we see with the young old is that they're actually more adherent than the middle-aged adult, but that changes as people get into the older age groups. And so whether or not people, when they come out of or they're coming into retirement, take with them the skills that they've had to use to manage their lives. So the calendars and the lists and the other behavioral things that are so common in our lives. But then lose those skills over time because their lives become less demanding in terms of the scheduling issues. That's something else that I believe may be going on in one of the areas in which nursing in the community might be helpful, is to reestablish some of those strategies, and that we're still looking at. Okay, thank you so much for your questions. I appreciate it, and for the support from the group. Okay.
I guess we're awake. We're interested.
Okay, so are we going off here? If you want a handout, I would be happy to get one printed and get it to Lily or send her it as an attachment. I honestly did not know what was involved because things had come pretty late in the game.